Hey everyone, Dr. Eric here from MedBetterHealth. Let me ask you a question. Did you ever wonder what is the proper evaluation to evaluate yourself or your loved one if you have dementia? Well, I've got the answer for you. And not me, but I have the greatest of all time, Dr. James Galvin, on the show. And this episode, we talk about how do you get evaluated for dementia. Are you ready? Follow me along. So we know that it's important to know, okay, you have dementia, what type of dementia? Here's an incredible statistics, and I know remind me, are you on the board of the Alzheimer's or involved with the Alzheimer's Association?
Yes. Yeah, I sit on the board for the Southeast chapter, right.
So I know that's what I'm asking. An article came out from the Alzheimer's Association and hit me, and I'm like, wow. It said that 40% of clinicians, providers, doctors, nurse practitioners say that they don't feel comfortable or lack the tools of making a dementia diagnosis. So for example, in the state of Florida, we say that we have 720,000 people that we assume have Alzheimer's disease alone. Not just dementia, but Alzheimer's.
Mm-hmm.
If 40% of folks say, well, we don't feel comfortable making the diagnosis, is it really 720,000 that have Alzheimer's, or is it a lot more? So the question that the audience wants to know, I go to my PCP, I go to my neurologist, I go to somebody. What's the criteria? What are the steps? What entails being diagnosed that I have a dementia? Not the specific one, but at least saying I have a dementia.
Yeah. So, I think that's a great question. So there's a couple different approaches, right? So one, the patient may discuss with the provider, that they're noticing some changes in their memory.
Mm-hmm.
And they may or may not be good historians, because people who have memory problems may not be the best storytellers about what's happening. The spouse or family member may talk to the doctor about the changes they're noticing, or the provider may notice. So you have someone you've been treating for diabetes, and now their diabetes is less controlled because they're not able to keep track of that regimen, and they're missing medications, and they're not following the guidelines, and their hemoglobin A1C goes from like 5.9 is now at 6.3%, even though you've been treating them. And so there are three kind of things. The doctor may notice, the family may notice, the patient may notice, but then the doctor has to be in tune with that, right? And it's really challenging to practice medicine today. You know this, right? There's a lot of burden with electronic health records. We're all on these, or almost all of us are on these relative value unit or RVU systems where, it's just an assembly line, and, you get 15 minutes with the patient or 20 minutes with the patient, and then there's 100 people in the waiting room and you have to get through them. So it's very difficult to figure out how to address these things. But a smart customer is the best consumer, right? And so a patient who's coming in and can get that information to the provider, that can trigger the provider to take the next action. And that could be during this visit, or they could schedule a follow-up visit to specifically address the problem. Because what often happens is you're finishing up with the visit, and the patient says, oh, by the way, and I don't have any more time to spend with you. So the next thing was, well, let's get you back in a week or 2 weeks, and let's get this worked out, right? So patient can complain, the family can complain, or the clinician can notice the changes because the patient's different than they used to be.
So notice the changes, so the complaint. So that's kind of like step one. A lot of the times when folks go to the doctor's office, and when a doctor may feel, or a clinician may feel uncomfortable making the diagnosis because the statistics, 40%, very often they say, oh, it's just normal aging. And so what tests would one have to do? Is it, I know back in the day we had spinal taps and all this other stuff. What is the first step that one would do in the algorithm of that workup to start working someone up for dementia?
Right. Well, I want to say something important. So everybody should listen to this particular fact. There is no memory loss that's associated with aging, right?
Huh.
Memory loss is not part of the normal aging process. It takes you longer to do things. It takes you longer to remember things. It takes you longer to remember what you had for breakfast. It takes you longer to remember that person's name who's coming towards you. It takes you longer to balance your checkbook, if anybody does that anymore, right? But you still can do it. You remember that person's name. You think about it. Oh, yeah, I had oatmeal for breakfast. And you can do the math. It just takes you longer. That's age. Anything else is caused by something, and it's up to us as the providers to figure out what that something is. It doesn't have to be Alzheimer's disease. It could be poorly controlled diabetes, right? It could be cough medicine that people are taking and they're having side effects. It could be due to a lot of different things, but it's not aging, right?
That's a very important, because a lot of people say, oh, it's my memory, but it's because I'm just aging.
No, it's not true, right? And so the second part is that the first step of this is to try to have the primary care clinicians, do some form of assessment. So the Welcome to Medicare exam and the annual wellness visit both require assessing cognition, right? That's a requirement of getting those visits. Now, the problem is that they're not prescribed as to how one does it, right? So someone could say, how's everything? And if you say fine, they technically check that box. But what they can do is there are very, very simple, brief tasks. They're not perfect, but they don't take a lot of time, right? So there's a test called the mini-cog, which is 3 words and then drawing a clock, right? And then ask that person what those 3 words were. Very, very simple test. And if you have either trouble remembering the words or drawing a clock from memory, that would suggest, we need to do some other type of evaluation.
And that's kind of like a great entry screening test.
Entry
right? Like
screening
a really
test.
quick 5-minute kind of a thing. And then, okay, if you didn't do well on that one, let's go deeper.
Right.
With either an MMSE or a MoCA.
Or whatever test you like, right? There's lots of them out there. When there's lots of things that reportedly do the same thing, none of them are perfect, right? But they all can help make that, decision that there is a problem, okay? So first is that screening, right? So we screen and we say, something's going on, let's investigate it. The next part is doing a really, really good neurologic exam, right? Because diseases like Alzheimer's have relatively normal neurologic exams, and diseases like Parkinson's or Lewy body dementia or vascular dementia have abnormal neurologic exams. So we want to do that neurologic exam because it helps us sort of make our differential diagnosis, make our list in our head as to what could be the possible causes. Then we want to do a little bit more detailed testing, right? So we'd like to do something beyond that brief screening test. And then we're going to do laboratory evaluations, right? We're going to look for the cause, right? That includes a complete metabolic panel if that hasn't been done, right? Looking at hemoglobin A1C, make sure that that's under control. Looking at their thyroid function, looking at their vitamin levels, because those things, if they're abnormal, could be potentially reversible just by correcting those things.
So you're saying diabetes, because I've noticed in today's talk you've mentioned hemoglobin A1C, which is a marker that we measure every 3 months to see where your blood sugar is and whether you have prediabetes or diabetes. Why is that so important in memory?
Because after age, diabetes may be the second most common risk factor for developing diseases like Alzheimer's disease. And it's very treatable, right? So while it might not get rid of all the memory problems, people who have poorly controlled blood sugars and elevated hemoglobin A1Cs are going to do much worse on cognitive tests than people whose sugars are better controlled.
Oh, wow.
Right? So we want to look for all the things that are reversible or treatable, right? And so we're going to do some of those basic laboratory tests. Then we're going to get an image of the brain. We're going to take a picture of the brain. And the best picture is going to be an MRI. By far, it's going to be the best picture, right? Because it gives us much, much more detail at a much, much thinner resolution, right? So we can see things that we can't see on other types of images, right? And we're going to look for structural problems like stroke, a tumor, infection, other types of things, again, that are more directly addressable. And if we don't see any of those things, then that would suggest we have one of these, primary neurological diseases like Alzheimer's or Lewy body. And then in today's world, we now have, and I think we're going to talk a little bit about this later, we have blood-based biomarkers. So we have blood tests available, right? And there's a blood test available in the primary care setting, which is to rule out Alzheimer's disease. And there's a blood test available in the specialty setting, which is to rule in Alzheimer's disease. And so we have these complementary blood tests that help us make these diagnoses.
Yeah, and we'll talk more about that because I know a lot of people are interested in hearing about that. But before that, a lot of the times I use this example with my team, with everybody. It's the story of the logs falling from a mountain, from a river. And these logs, they're falling down, and people are just cleaning those logs and cleaning those logs. But nobody asks the question, hey, we're cleaning all these logs. Where are they coming from, and who's throwing them, and how can we stop them from falling down so we don't have to clean them all day long? The reason I lead with that is because I want to talk about prevention. People always ask, well, what medications, Dr. Galvin, can I take so that my memory is good? What vitamins can I take? But besides that, are there any other things? And I'm a very big believer in that. We were created for a certain way as humans, eating natural food, exercising, walking. That's kind of like a creation. I'm here in this world and I'm going to do it. If I do something unnatural, it may take me off the spot, right? Now, if you got value from this video, I want you to imagine a world where caring for your loved one with dementia doesn't mean doing it alone. Imagine a world where you can have someone to help you at home taking care of your loved one. And imagine a world where you have 24/7 access to support when you need it. Well, I got good news for you. You don't have to imagine it anymore. This is now a reality, and it is now covered by Medicare. If you're interested in learning more, very, very simple. I want you to look up over here. We have our link to our website. Visit our website, scan our QR code, look in the description for the link as well. And don't imagine anymore. This is now a reality.